She has vast clinical and research experience in the field of rheumatology, and she's an active member of pediatric rheumatology and osteoporosis special interest groups. Welcome, ma'am.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Babar, for this wonderful opportunity. I've been asked to deliver a talk on treat-to-target approach in osteoporosis. Now, we are all familiar with treat-to-target. It is a goal-directed strategy which is used in the management of chronic diseases. So what happens is that we choose a measurable target for our patient, and then we put them on therapy. We continue monitoring the patient to make sure that the patient is on the right track. And then we modify the therapy if we feel at any point that they are lagging behind their target. We have seen this therapy work in context of management of hypertension, in context of management of diabetes mellitus, and more recently in context of rheumatoid arthritis. So now the burning question is, can this same framework be applied to osteoporosis? And this is what I'll be dissecting in today's presentation. Right, so first things first, let us answer this simple question. Why do we need a treat-to-target therapy in osteoporosis? And the answer is there are many reasons why. First and the foremost, we know that it is a proven rule. We have seen it working for patients of rheumatoid arthritis. We have seen that patients who were treated to a target had better outcomes in rheumatoid arthritis. We then saw its introduction in the management of SLE patients for axial SpA. So why not try it in osteoporosis as well? Secondly, I think we have all noticed that even after decent gains in BMD, sometimes our patients go on to develop a fracture. This means that there is some gap in our treatment, and that gap can be identified and managed very well if we apply a treat-to-target therapy in osteoporosis. And lastly, we have many drugs now available for the management of osteoporosis, like, for example, anabolic drugs and anti-resorptive drugs. Sequencing them needs a objective trigger, and that trigger can very well be obtained through treat-to-target approach. So this is now a paradigm shift in the management of osteoporosis, where we define a specific T-score for our patients and assign them a risk, an acceptable risk of fracture, and at the onset of the treatment, and then we escalate, switch, or sequence their therapy accordingly. So the result is a proactive, risk-stratified care for our patients, as opposed to a reactive treatment that we have been given them all these years. So this concept the concept of treat to target was first introduced by Cummings et al. In 2013 in the form of two simultaneous papers, which were published in March. And what the authors proposed was that a treat to target strategy should be applied while managing patients with osteoporosis, and they proposed 4 different steps. Number one, they suggested that all the patients should be assessed for their risk of pathological fracture before putting them on any treatment. Number two, they proposed that initial therapy should be with a drug that is most likely to achieve an acceptable level of fracture risk for that patient. Thirdly, we should reassess the patient's progress at appropriate intervals to make sure that they are on the right path. And lastly, we need to modify their treatment as needed to reach and maintain the desired target. So once this concept was introduced, the American Society for Bone and Mineral Research and BHOF then constituted a task force who issued their the first progress report in 2017. The task force then reconvened in 2024 and published an updated position statement. So today's presentation is mainly based on this position statement issued by American Society for Bone and Mineral Research and BHOF. It is important to note here that this is still a position statement and has not been formally incorporated into any clinical practice guidelines. So these are the 4 steps while considering a treat-to-target approach in osteoporosis. Number 1, we assess the fracture risk of the patient and assign them with a target. We start the treatment of the patient, then we reassess the patient, and finally, if any adjustment is needed, we make the adjustments in their therapy. Now, in the subsequent slides, I'll be looking at these steps in detail. So first step is defining the goal for the patient. Now, this is very important, and this goal is based on their fracture risk. So the first and the foremost goal, of course, is to bring their fracture and their risk of fracture to an acceptable level. Of course, we cannot 100% eliminate it, but we can bring it down to an acceptable level. And this is the first target for all the patients with osteoporosis. And then we also assign them a second goal, which is that they should be able to gain a BMD, a specific BMD level, and that can serve as a measurable goal of therapy that we can keep an eye on. So why are we so obsessed with fractures? And there are many reasons. We all know that fractures can play havoc with a patient's life, but also because we know that once a fracture happens, it puts the patient at an imminent risk of a subsequent fracture. So we have lots of data concerning this, and it confirms that recent fracture is a strong predictor of subsequent fracture. And the risk rises very rapidly after the first fracture. It is highest within the first few months and remains elevated for up to 2 years. So this is very important that we prevent the first fracture from happening. And if the first fracture has happened because of any reason, then we must act fast and try to prevent the subsequent fracture. So in patients who are at an imminent risk, rapid and maximum fracture risk reduction is the primary treatment target for us. And also, this is also true for patients who have had multiple fractures in the preceding 10 years. This kind of history also puts them at an imminent risk of subsequent fracture. So here again, treatment targets include attaining higher T-score goals than usual thresholds. These patients may also require a more prolonged and intensive course of therapy, even after reaching the T-score targets. And I also talked about assigning a specific BMD level to the patients. So the minimum target T-score for all the patients with osteoporosis should be anything over -2.5. This is because once this target is achieved, they automatically come out of the range of osteoporosis. And the site where we should be looking at for this score is total hip. And the reason why we have chosen total hip is that we have seen over the years through different studies that mean total hip BMD after treatment predicts the subsequent risk of both non-vertebral and vertebral fractures. However, this is the minimum T-score requirement. For some patients, we will have to aim for a higher target score. And these patients include patients at an advanced age, patients who have an increased risk of falls or those who are physically challenged, and of course the patients who have had a past history of fracture. So here we have to aim for higher targets, somewhere in the range of -1.5. And the supporting evidence for this comes from the ARCH trial, which was a head-to-head trial comparing the efficacy of romosozumab with alendronate. And all patients enrolled in this trial had a prior history of fracture at baseline. Subsequent fracture risk declined. It was noted that subsequent fracture risk declined progressively as 1-year total hip T-score approached -1.5. So a target of -1.5 is a good enough target for these patients. And lastly, we also have to aim for a higher T-score target for patients who are being treated with bisphosphonates or whose most recent treatment included a bisphosphonate. So here the goal is not minus 2.5 itself. It is a target high enough to still be above minus 2.5 after accounting for the holidays bone loss. So we know that they will go on a drug holiday and they will lose their BMD. So prior to putting them on holiday, we have to increase their score to a reasonable level. Now, the step 2 in treat to target approach is choosing the right therapeutic agent and planning sequencing where needed. Now, this is a very important step. We know that we have anti-resorptive drugs available and we also have anabolic drugs available. So which drug should be chosen as the first line treatment? Here again, we, through the results of different famous trials like Freedom Trial, Horizon Trial, and Flex Trial, we know that while all anti-resorptive drugs increase total hip BMD, the magnitude differs consistently across agent classes. So it has been seen that the largest gains are seen with denosumab, followed by zoledronic acid, followed by alendronate. So if somebody has a really low T-score, then alendronic acid would definitely not be a good choice. Similar is the case with anabolic drugs. We know that some drugs are more potent than the others. Here we know that romosozumab is the most potent agent, followed by abaloparatide, followed by teriparatide. Now this position statement also answered a very practical question, and that is the probability of attaining T-scores more than minus 2.5 by a specific drug. So these position statements actually established the lowest baseline T-scores at the various regions, which can then direct us towards choosing the appropriate treatment for the patient. Like, for example, we get to know that if a patient has a T-score of less than minus 2.7 at hip joint, then they have less than 50% probability of increasing their T-score with alendronate. So alendronate should not be chosen for these patients. Similarly, if their score is below minus 2.8 at hip, then choosing denosumab would also not be a very good choice because they have more than 50% probability that they would not be able to achieve their target T-score, and so on and so forth. Through this position statement, we also learned that treatment sequence matters, and we have seen this through the various trials conducted in the past. We know that hip BMD is highly sequence dependent. So when we switch somebody from bisphosphonate to teriparatide, it has been noted that hip BMD falls below baseline for 12 months. And if they are switched from bisphosphonate to denosumab, then from denosumab to teriparatide, then hip BMD stays below baseline for nearly 24 months. Now, this is a very important finding. Whether this translates into a meaningful increase in fracture risk is debatable, but it has been seen consistently that their T-score falls below baseline when this switching is done. However, conversely, if we add teriparatide to ongoing therapy with alendronate, that results in improvement of hip BMD and improve in hip strength. So switching to teriparatide would not be a good idea, but combining teriparatide with alendronate is a better idea. So the position statement recommends, when possible, start with anabolic therapy first, so you don't have to make the switching, and then switch to anti-resorptive agents if need be. This is true for teriparatide, which is available in Pakistan. However, if we consider romosozumab, I'm sorry, this slide is missing here, but if we consider romosozumab, it has been seen that if a patient was being treated with bisphosphonate and they were then switched to romosozumab, their hip T-score did not decline. So this is a good switching. So rather than switching to teriparatide, you can switch to romosozumab. And same is true for switching from denosumab to romosozumab. But the sad part is that we do not have Romo in Pakistan as yet. So I've combined the third and the fourth step basically. Third step is progressive monitoring of the patients, and the fourth step is adjustment of their therapy. And both these steps go hand in hand, so I've combined it. So we have to determine if the treatment targets have been met by the patients. Now, if a patient develops a fracture while being on a specific treatment, then this is clearly the failure of that treatment. Similarly, if the patient fails to reach their target T-score, then this is also considered a failure of the therapy. So in these cases, we have to reevaluate the patient and see if there are any contributing factors. For example, if the patient is on steroids, we need to stop their steroids. We should try to reduce the steroid dose and try to taper them off completely. If they are smokers, we should encourage smoking cessation. And if they are alcoholics, that should also be discouraged. So here, if the patient was on an anti-resorptive drug, we can consider switching or combining an anabolic agent like teriparatide or romosozumab as appropriate. And if the patient was already on anabolic drugs, then this is where the things get a little interesting. According to the position statement, we can consider increasing the duration of anabolic drugs. Traditionally, we have been taught that teriparatide can be given for a period of 18 to 24 months only. But recently, FDA has approved its use beyond 24 months in USA and also in Canada. So that can be considered. And if they have had a course of teriparatide or romosozumab in the past, we can give them a repeat course. Conversely, if the treatment target has been met, then we can consider switching. We can consider a drug holiday for the patient if they were on bisphosphonates. If they were on denosumab, we can either continue giving them denosumab or we can transition their therapy to a bisphosphonate. And if they were on anabolic therapy, once they complete their treatment duration, we can switch them to any powerful anti-resorptive agent. So lastly, I would like to consider a couple of clinical scenarios, and let's see if we can apply this treat to target approach in these scenarios. So the first scenario is of a postmenopausal woman who presents to you in your clinic with a T-score of less than minus 2.5. She does not have a prior history of fracture, and her risk of fracture is low to intermediate. So here, what is the minimum target for this patient? Anything over minus 2.5. This should be the minimum target. And for most patients, bisphosphonates or denosumab can work very well. However, if their T-score is very low, then we must consider therapy with an anabolic agent. And the point here is treatment intensity should be matched to the baseline severity of fracture risk. Scenario 2 is of a patient who has had a fracture in the past, but that was more than 2 years ago. So here we can encounter two scenarios. In the first scenario, if the patient has a prior history of fracture, but their T-score is less than minus 2.5, then again, the minimum target is anything over minus 2.5. And for initial treatment, we'll have to see where did that fracture happen. If it was a vertebral fracture, if it was a hip fracture or a pelvic fracture, then of course we'll have to consider therapy with an anabolic agent. If the fracture happened elsewhere in the skeleton, then we can consider bisphosphonate, denosumab, or anabolic therapy if the T-score is really low. In the second situation, the patient has had the fracture, but their T-score is still above minus 2.5. So here the minimum target is to increase total hip T-score by 0.2 T-score units and their lumbar spine T-score by 0.5 T-score units. And here again, the initial therapy will depend on the site of fracture. If it was a vertebral or a hip or a pelvic fracture, we should consider treatment with an anabolic agent. And if it was elsewhere, we can consider bisphosphonates or denosumab. So third scenario is pertaining to patients who have an imminent fracture risk. And here the indication is the history of recent fractures in the preceding 2 years or history of multiple fractures in the last 10 years. So this is a high risk group. And here, treatment target is not minus 2.5. Here, we have to aim for a maximal rapid reduction of fracture risk, and anabolic first therapy should be considered. However, if the T-score is not too bad and the fracture was at a site, at a non-vertebral hip or non-pelvic site, then bisphosphonates, denosumab, or anabolic therapy, any three of these can be considered. So the take-home message here is that T-score does not gate the treatment intensity here. Recent or repeated fracture alone mandates the use of the most potent option available. And lastly, we have the case of a patient who comes to us with a very high risk of fracture. However, they have never fractured before, and also their T-score is over minus 2.5. So what to do here? The minimum score, the minimum target for this patient should be an increase in total hip T-score by 0.2 T-score units, or an increase in lumbar spine T-score by 0.5 T-score units. And since they do not have a history of fracture and they do not have osteoporosis as yet per se, we can consider initial therapy with an anti-resorptive agent. And the key point here is that high frax risk without fracture warrants treatment, but just not with the most intensive agent available. So in summary, the goal of osteoporosis treatment is prevention of fractures. We all agree with this. Number two, we have learned that response to treatment is not the same as having an acceptable level of fracture risk. I'm sorry, the slides got a bit distorted here. Thirdly, we learned that any treatment is better than no treatment, but some treatments are better than the others. And lastly, treatment decisions should be individualized for every patient. One size does not fit all in osteoporosis, and this is what treat to target approach means for a patient with osteoporosis. Thank you very much.
Thank you so much, Dr. Taqdees. The house is now open for question and answers. If you have any questions for our speakers, you can please raise your hands. Sir.
Excellent two talks. But question first to Dr. Taqdees. Where is she? Dr. Taqdees, excellent guidelines and excellent line of treatment. But looking at the practicalities of treatment here in our setup, you are relying on DEXA scores. And the DEXA scores that we see available in the market are not really all of the same standard. Have you come across that? How do we address that issue? Secondly, some DEXA score providers are giving an extra DEXA score of the wrist, which really is not included in the guidelines. Why are they doing that? And it just confuses the issue of treatment to those who are not as good an expert as you are. And the third practical question, yes, anabolic agents are excellent. The price is prohibitive. And we see these old women, we belong to a poor country, most of the people coming up with these very poor T-scores are poor themselves. So the treatment becomes impractical. So I'd like to have your thoughts and comments on these three issues.
Sir, thank you so much. I think all of these comments are very pertinent, very relevant to osteoporosis management. Sir, addressing the first part of your question regarding DEXA score variability, I think this is where we can make use of validated tools. We can use FRAX index, FRAX score, and classify patients according to low, moderate, high, and very high risk, and proceed with the treatment accordingly. And a history of fracture can also guide us in this respect. We should also take into account their risk factors. If they are present, we should try to eliminate them. But that does not entirely solve the process and the problem with the DEXA score and DEXA scan and the T scores. But I think this is one way of going around. Second part was regarding the risk. So, risk is considered in cases where we do not have T-score available at the hip joints. For example, somebody who's had bilateral hip replacements, obviously we wouldn't have their T-scores available for hip area. And also for those patients where we know that they are suffering from lumbar spondylosis and their spinal score is not very accurate because of calcification or because of osteophyte formation there. So in those cases, we can consider risk and we can consider the scores of the risk. And so thirdly, about the cost of the therapy. So that is definitely an issue, but I don't know how to answer that. But I think there's one thing which I'd like to highlight is the one thing that is pertinent here is that all the data that I presented was from Caucasian postmenopausal women. I am not sure whether it can be applied to our local population. I think we need to come up with our own data first and then see what we can do about it. And otherwise, you're absolutely right. The cost of treatment is still very high. So maybe we should focus more on the preventive side rather than on the therapeutic side. We should raise awareness about osteoporosis in public, tell them about the advantage of taking a wholesome diet, exercise, etc.
Thank you. You answered all three questions. But you know, my philosophy of treatment here in our setup has been to provide a treatment that is affordable and practical. Yes, we must know all these guidelines that you just mentioned for this and all other diseases that we treat. But then we need to modify what we are able to give to our patients. We cannot just prescribe something that is unaffordable to them because that will not work and we will not be treating anyone. Just to give an example, when we talk of biologic agents and anti-TNFs came first and all guidelines would mention that if DMARDs fail, conventional DMARDs fail, you should give a biologic. We chose to give rituximab because that was much cheaper and it did not have the same risk of reactivating tuberculosis. So the same concept would apply here. So I would appreciate your approach to our patients. Those were the guidelines. How are you going to treat the patients that we see on a daily basis? You are now quite an expert on this, so your approach would serve as a model for everyone else. So what would be your practical approach to the patients that you see in the clinic?
So if the fracture risk is not very high, I think I would still go for zoledronic acid, which is easily available and not that expensive for the patients, and it covers their treatment for the whole year. So I think in our local setting, we can go for zoledronic acid, which is still a good enough choice. We have seen that. And also, I think screening early would also be helpful. If we screen them at an earlier phase when the T-score is not very low, they can still get away with alendronate or cheaper options. However, if they come to us very late in the disease course, then of course we'll have to resort to the more expensive treatments. But I think in my clinical setting, I would prefer zoledronic acid over other agents. I would also like to know your thoughts on this.
Taqdees, can I ask you, if with your permission, I'm glad that you are part of the osteoporosis. And I remember that we had a presentation from Thailand where they did their own fracks for Thai women and they generated their own data. Do you think it is feasible to generate that kind of data for Pakistani patients? Because these are guidelines coming from the West, and I'm sure if we had data, it will be much more of an informed decision. And just as Abid was saying, that we can perhaps guide them better. That is one. Second one is your thoughts on fracks. It concentrates on hip fracture, but a lot of morbidity is coming from the vertebral fractures. How do you address that? Or is there any tool where you can look at the risk of vertebral fractures besides the hip fracture?
So to answer the first part of your question, we tried to gather that data from Pakistan. We applied for a COPCOD grant. Unfortunately, it was not granted, but I think that is something worth doing. We need to do that. We need to have our own data. And coming to the second part of your question, this is the main limitation of FRAC score. So now we have to take into account the recency of the fracture. Time also matters, as we have seen. The site also matters. The number of fractures also matters. The dose of steroids given to the patient also matter. So the FRAX tool that we use has all these drawbacks. However, they are now coming up with another version of FRAX by the name of FRAX Plus. It is not freely available as yet, but that tool has sort of addressed most of these issues.
I have a question for Professor Uzma, so let you off the hook. Very interesting talk on myositis. Just regarding MDA5, because I think historically it was more prevalent in Japanese population based on case series, case reports. And in Malaysia, we've seen more MDA5 being detected with high mortality rates. Do you also see a similar in terms of MDA5 myositis here in Pakistan?
There are few cases. We have not come across many cases. There are few 4 to 5 cases I think I have came across with this. One of them was associated with cutaneous finding, and other was associated with lung findings. So there are not as much prevalence as in the Japanese, but maybe because of the lack of these myositis specific antibodies and their detection and their limitations of detection. So maybe we are not picking up at that end. And on the other hand, we don't have too much data on the myositis. So it is a rare disease, we know. Maybe in future, we come across with more and more cases and we try to identify these cases. Maybe these cases sometime come to first to the dermatologist or maybe to the pulmonologist. And it is depending upon their acumen that they pick up these cases and refer properly to the rheumatologist. Maybe we have multidisciplinary CPCs with our dermatologists and pulmonologists, and we let them know that these are the conditions where you can pick up these myositis cases, which are predominantly presenting with a dermatological finding or with the respiratory finding. So there are not much cases, but maybe they're underdiagnosed. Thank you.
Thank you.
Sorry, just about osteoporosis bit. Just regarding pre-osteoporosis, if you like. You guys might have read about the recent article, randomized controlled trial published in New England Journal of Medicine. What they looked at was the postmenopausal, early osteoporosis, not rather early osteoporosis, pre-osteoporosis. What they gave was zoledronic acid once in 5 years in one arm. The other arm was given zoledronic 1 in 10 years, and the third was no drug. So definitely the zoledronic acid given in 5 years or even in 10 years was far superior to prevent fractures, was far superior to prevent osteoporosis. So that in talking about like being preemptive, that would be the one thing if we come across with any postmenopausal who you think might be approaching towards osteoporosis early, has not reached even osteoporosis yet. So that might be the one way to go. And that is a randomized controlled trial.
Dr. Uzma, thank you very much for the wonderful talk. This question is that in dermatomyositis, as per the recommendations, you need to screen for the malignancy on an annual basis. So do you still recommend that getting anti-TIF antibodies considering the cost? Because does it make a difference to get anti-TIF antibodies just to check the patient is a high risk? Because already a dermatomyositis patient is a high risk patient. So why to go for an anti-TIF antibody? Just go for a screening once you see a patient of dermatomyositis.
And thank you so much for this question. And Dr. Babar, with changing era, these myositis-specific antibodies are defining the risk stratification and guiding the treatment. So once you diagnose a patient with the dermatomyositis, he or she is already, and if that person is above 40 years of age, it means he or she is in high risk category and need to be screened for malignancy for 3 years. So TIF antibodies, if the TIF antibodies are positive and there are 2 more risk factors, according to the IMAX guidelines, these patients should undergo PET scanning in addition to the routine CT scans and tumor markers. So I think there is some difference. And we don't have these CCAR antibodies which define the cancer stratification in patient with TIF1 antibody positive. Where the CCAR antibodies are positive, there is low risk of malignancy, and where CCAR antibodies are negative, there is high risk of malignancy. So I think when you are planning to go for PET scan for when some history or clinical features suggest that this patient have increased risk of malignancy, so you should go for it.
Okay.
Thank you.
Dr. Taqdees, just a brief question. What percentage of patients, do you have any data which shows that what percentage of patients face fracture who have a very high risk and have been treated with bisphosphonates? Because if the number is quite high, then there is no use of giving bisphosphonate, even the cost is cheap. Because if we are treating the patient for the next 2 years, and after 2 years, we find that the patient has faced a major fracture, and that will cost as well. So if the number is statistically quite significant, then that makes sense that we should be very, very practical giving bisphosphonates only rather than jumping onto the anabolic treatment. Because, so any data regarding that for high-risk patients?
There is a lot of data, and head-to-head trials have been done, and there is significant risk reduction seen. Many fractures have been prevented this way, but I'm not sure about the exact numbers, exact figures, but all these data, all these studies come down to the same point that prevention is definitely better.
I think that Professor Sir Abid was saying that, are we seeing just the DEXA scan scores, or are we seeing the prevention of the fracture as well?
Prevention of fractures as
Because
well.
if it is significant,
No, if-
then that makes sense that should we really give cheap treatment, and even after 6 to 12 months, we are facing a fracture, that will also cost something. So
denosumab has shown superior results in Freedom trial and Freedom extension study. This was significantly as significant number of patients did not go on to develop fractures compared to those who were not getting denosumab. So yes, there is evidence that treating them is needed.
Okay. Thank you.
Can I just take this opportunity to thank the wonderful talks and the question answer session. I couldn't help but come up and relate a little life experience. But before I relate that,